Hey, good evening. This is Matt Matava. I'm the Chief of Sports Medicine at Washington University in St. Louis, and with me is my partner, Matt Smith. Matt, you want to say hi to the group?
Hello, everybody. Good to see you tonight. Thanks for joining us.
Yeah,
So
so tonight
tonight we're
we're
going to be,
go ahead,
go
Matt.
ahead. No, I was going to say tonight we're going to be talking a little bit about ACL injuries and some common questions that people have about how do I prevent ACL injuries? What happens if I get an ACL injury? Recovery time and expectations, and hopefully we'll get some education for everybody. And we got a nationwide expert in Dr. Matava on the topic, and hopefully I'll provide some good information as well. So, Matt, I'm going to talk to you first. So when somebody comes in the office and they tear their ACL, I think one of the things that I get a lot of is, could I have done anything different? Was there a way to keep this from happening? Because everyone hears about an ACL and they know they've had a friend or a family member and they know it's a tough problem. And I think the first question a lot of people have is, could I have done something different? And what do you tell people?
That's a good point. First of all, you want to try to let them know that, this happens to a lot of people. I grew up in St. Louis. I played sports. I know you played sports. I think I knew one kid when I was in high school who had an ACL tear during my entire 12 years of school that had an ACL tear. Now, it's not uncommon to have kids who already had their second ACL tear by the time they're 14, unfortunately. But no, I try to reassure them that this is not something they could have prevented. I mean, as long as they're being active, involved in cutting, twisting, and pivoting type activities, which a lot of kids do, we encourage them to be active, then this is not something they could have prevented. There are certain ACL prevention programs out there that help to strengthen the lower extremities to help reduce the risk of ACL tears during certain jumping activities. Certainly, but for the average kid who's playing sports or the average adult who's doing this in either a recreational capacity or injuries on the job, which we see quite frequently, there really is not something they could have done to prevent this injury. It happens very commonly. There's over 200,000 ACL tears in the United States alone. As you know, girls are quoted as up to 6 times more commonly injured than boys are for a variety of reasons, and certainly, sex differences do exist. But I appreciate your thoughts on this. I don't think there's anything that necessarily could have done differently.
Yeah, it's hard because I think a lot of people, when they have an injury, they wish they could hit the replay button and go back and do something different just before it happened. But I agree with you. There's really no way to prevent it, and I think the only way you prevent an ACL from happening is just not playing sports that involve pivoting or twisting, which is not practical because there's so many other benefits to playing sports that I think the risk is probably worth the reward in a lot of ways. I do think there's probably something to the repetitive overuse. I think the single sport athletes, particularly soccer, being the one that gets people often, I think that's a kind of a risk. And I know one of my mentors was looking at fatigue in the ligament as being a concern, that maybe there were, just like when tennis elbow or patellar tendonitis, maybe there's some fatigue in the tissue in the ACL that puts people at higher risk. Probably not a strong data to support that at this point, but I think there's something to overuse.
No, I agree 100%. And I think that goes back to my point making growing up here in St. Louis. Back then, I graduated high school in 1981. I'm dating myself, obviously, but, back then there were no select teams. You played, you played soccer, football in the fall, you played basketball, you wrestled in the winter, and then you played baseball, you ran track in the spring, and then you did it all over again. And you used different muscle groups, you met different friends, you developed different skill sets. And I think there's a strong reason that those injuries didn't happen like that. Now we have kids playing soccer all year round. We have in the warmer states in the South, they play baseball year round. And it's become an issue. There's lots of research going into this topic now showing that kids who play, one sport predominantly have a higher burnout rate. They have a higher injury risk. A lot of this is related to, again, overuse, as you mentioned, of the muscles, the lower extremities. They get fatigued, and it puts the ligaments at risk. And this what happens, I think. And this is a theory that's held by a lot of sports medicine specialists across the country, and it's an area of active research.
Yeah, and if you if you look at the studies in terms of the number of these injuries, and if you look at as you said early on in your career compared to where we are now, just the pure number of injuries has skyrocketed, and that we see that with ACLs, we see it with Tommy John injuries, we see it with all kinds of stuff. And I think the sports specialization early has really contributed to that.
Yeah.
What are your thoughts about playing surfaces?
Well, there is data that comes out from the NFL. The NFL is the pro league I had the most experience with from taking care of the with the Rams here, and they did a lot of research with playing surface, and at least their artificial surfaces had a 2 times higher ACL rate than grass surfaces did. And back again, dating myself, playing on AstroTurf. Perhaps you played on AstroTurf too when you were younger. It was almost like a carpet. Back then you wore like a tennis shoe to play on, and you'd stop on a dime, your foot would stop, your knee would keep going, and you'd tear the ACL. Now with field turf, it's not AstroTurf any longer, but it's a deeper plush surface. There is still, though, you wear the cleats that are made for that surface. You dig in deeper. Again, you stop on a dime, and your knee keeps going. So we encourage athletes to play on grass surfaces. Um, you know, Grass surfaces unfortunately take more maintenance, and so if you have a high school that has a certain budget, they often will go to field turf or a similar type surface just because it holds up to multiple sports. It holds up to bad weather. But I do concern myself when I see an athlete, especially when they go back to sports following an ACL reconstruction, that they may be more at risk for that. And then they've sort of expressed the same concern. I think the lay press has gotten a hold of this research, and I think the general public is starting to pick that up now.
Yeah.
Do you tell your
Yeah.
athletes anything to have them wear a certain cleat?
Yeah, I think I mean that's a good question, and I know that there's some studies you're probably more familiar with your involvement with the NFL about the optimum shoe surface interface. Again, we don't see those injuries as commonly in hockey because the foot's not planted, it's not fixed to the ground. It's usually going to be a collision that happens for ACLs in hockey, but for the stopping, pivoting, the thing that gets the ACL the most commonly, that shoe turf interface is probably a real issue. But I don't know if they've made any progress with that at this point, but that might be something on the horizon. It may be helpful for prevention.
Yeah, it definitely is an active area of active research. Do you tend to your clinic? Do you tend to see patients when they come in with a twist injury of their knee? Do they haven't gone anywhere else? They come straight out off. Do they ask you about getting an MRI? Because that's a common question I get. Do I need to get an MRI? What's your approach on getting an MRI for a person who has a twist injury of the knee? Maybe you think it's an ACL, maybe not. Can you go over that? Because it's a common question that comes to me and my patients.
Yeah, no, I think the clinical exam is often the most sensitive for me to pick up an ACL tear. So if you do an appropriate exam, and sometimes people are really sore and swollen, but we can generally get them relaxed enough to be able to tell whether the ACL is competent. And oftentimes, if somebody comes in and says, "Yeah, I planted, I felt a pop, my knee buckled." That's one of two or three things that come up right away in my mind, and the exam usually confirms it. But an MRI is often helpful to make sure we don't have any other major cartilage or meniscus injury that we'd want to know going in trying to treat that issue.
What would you say?
Yeah, go ahead.
What would you say when patients come in? They're always attuned to an ACL. You mentioned this a couple of the things you think about. What's on the differential diagnosis, as we call it, for the person who does come in with a twisting injury? They're unable to bear weight. What are some other things that might be besides an ACL that help you distinguish that from the ACL injury we're talking about?
Yeah, so the one thing that I think is often overlooked, and I've seen a handful of people who came in and were seen in the emergency department or urgent care. Oh, we think you tore your ACL, and actually they dislocated their patella. So their kneecap shifted out, so they planted, feel a pop, they feel something shift or buckle in their knee, and it was actually the kneecap that was sliding out of joint rather than the ACL. The other one would be meniscus, a common injury. Then and somebody in their mid 20s to mid 30s, and so you got to think about patellar tendon rupture. They planted, felt a pop, now they can't straighten their knees. So those are the main things. So meniscus, ACL, patellar dislocations are the ones that come to mind first. How about you? Anything else?
No, I think that describes the majority of them. The distinction I use a lot, help with the residents and medical students who come in and help distinguish between, a meniscus tear that's very common or an ACL is typically after an ACL tear, they can't continue to play. And oftentimes, I think I remember in 26 years of practice, I've had one athlete that I took care of. She kept playing after an ACL tear. Didn't last too long, but I think they're probably in that situation, they may have had a partial tear that then went on and completed the tear later in the event. But for the most part, if you have an ACL tear, you can't play that game or continue with practice. Whereas like if you tear your meniscus, as you've seen, we've seen several several athletes done that in various sports. They continue to play the event, they complete the practice. It's not until the next morning they wake up. Now their knee's swollen, it's sore, it's painful, it's stiff, it hurts on the joint. Then they know they have a problem. And a corollary to that is usually with an ACL tear, you'll get swelling with the knee within 6 hours, whereas with a meniscus tear or the other conditions you mentioned, toe instability, they may take 12 to 24 hours before they notice any significant swelling. Or the patient goes to bed that night because the game was that evening, and then they wake up and their knee is stiff and swollen. So the history, not only about the event of the injury, but also their symptom history, I think to me is very helpful in discerning this diagnosis from other very common conditions.
Yeah, no, I think that's a great point. So going back to the comment of returning to play, so the hopeful question I get all the time is, well, can I go back? Can I play? Can I finish the season? I know what your answer is going to be, but what do you tell people when they say, can I go back to play and can I try to finish the season with this ACL injury?
I mean, it's the reason I shake my head. It happened today. Okay. And so it happens a lot this time of year with football and beside the COVID effect of football, during this time of the season, you're into your high school football season. Playoffs are sort of around the corner. Your team is doing pretty well. Maybe you're a senior, unfortunately, and someone has a tear. What I tell them is there's two answers to that. First of all, the short-term answer is, can I help my team on the field if I go back to play now? That's the short-term effect. Second of all, what's the long-term effect if I go back to play? And so one of the things we might talk about in this session is the existence of other injuries too, besides the ACL tear. You could also tear your meniscus, which are the two little cartilage discs. About 60% of the time you tear your ACL, you have a coexistent tear of the meniscus. And it's been shown through research that if you have just an isolated ACL tear, that if you go back to try to play on that tear, that you have about a 30% chance or higher of tearing the meniscus now through that second injury that you didn't have after the original ACL tear. So you may actually do further damage. We talk about the meniscus is there to protect the articular cartilage. Well, the ACL is there to protect the meniscus. And so it all works in a chain. And so once you tear that ACL, further injury can occur down the line. So there's a short-term effect of I might do further damage. Then there's a long-term effect of whether or not I have long-term risk down the line of arthritis and that sort of thing. But then the more common thing to the sport and the present is whether or not they actually can compete. It's one thing to say I want to go out and try. It's another thing to be able to run, cut, pivot, jump, depending upon your position. If you're a running back, if you're a receiver, if you're a lineman, where the players are coming into. So even with bracing, oftentimes these kids and not even only kids, but also adults at the professional levels can't go back to play. But to answer your question in general, I encourage people not to go back to try to play with an ACL tear because I think the risk outweighs the benefit. If my kids had an ACL tear and they played sports, I would not let them go back to play with an ACL tear until it was fixed.
Yeah, and for those of you watching, the ACL, if you imagine this is my tibia and this is my femur, the ACL controls the forward movement of the tibia, but more importantly, it controls the rotation. So the reason why people have a hard time stepping and twisting is that they can plant and then they start to rotate and the ACL doesn't control that and he wants to shift and buckle on them. So anything that involves changing direction is really hard for these athletes to be able to tolerate. And I'm with you. I think, we talk about arthritis risk. The meniscus is the status of the meniscus is the number one thing that puts you at risk down the road for arthritis. So if you tear your meniscus and you chew that meniscus up and you lose the meniscus, the cartilage surfaces, which are the cushion for the joint, they'll wear out a lot faster than if you didn't have a meniscus tear. And that's one thing that I really think is important to protect. Short of just, getting patients back into the sport, I think protecting the meniscus is the priority as much as we can.
Now, one thing Matt talked about now compared to back then. Back then when I actually tore my ACL in 1983 playing basketball. Back then, if you tore it on a Friday night football game or a Saturday basketball game, you were having surgery Monday or Tuesday. Talk to us now about kid comes in, they tore their ACL in soccer practice yesterday. They come into see you today. It's an ACL tear for whatever reasons you've diagnosed it. What do you tell them? You can send them for surgery tomorrow if they want to do surgery. What's your approach to that patient?
Yeah, and that's a great question because a lot of people are, hey, I tore my ACL. I need to get back. Let's go. Let's get it fixed. And we had some data from our colleagues out in Colorado who used to take people off the slopes and fix their ACLs right away. And they tended to get a lot more stiff than they needed to be. And I think of it as two insults to the knee. So you have the traumatic injury of your ACL that causes an inflammatory response. And if you add a second insult during that inflammatory response from the first insult, you have a much higher chance of having that knee get stiff. I personally find that if you let the knee have a couple, 2 to 3 weeks to cool off and not be as inflamed and irritated and get the muscle firing again, I get the range of motion back. The recovery time after the ACL reconstruction, the time it takes for people to get their knee feeling back to normal is actually shorter than if you rush into trying to do it quickly.
Mm-hmm.
And I think, there are scenarios where we have to do it quickly. And if they flip a meniscus in the front of the knee, or have some significant cartilage injury with a loose body, which doesn't happen very often, I think that may push it sooner. But I typically let the knee cool off and give them a chance to have an easier recovery after surgery. What's
Back
your approach?
when I had mine fixed back then, the incidence of knee stiffness, permanent knee stiffness, was about 40%. So about 4 in 10 people had some loss of motion, typically loss of extension. They couldn't get their knee straight. And that's the most important thing we worry about, is getting it straight. It seems counterintuitive. You think that getting the bend back would be the most important thing. Actually, it's getting it straight that's harder. Now, with the program you're relaying, which is pretty much followed by most board certified sports medicine doctors, you wait a few weeks, you get the swelling out, get the range of motion back. That instance of permanent knee stiffness is less than 5%. So certainly that has made a big difference in the care of these patients. What about the kid that again is, let's say he's playing tomorrow night, Friday night football, twists his knee, has an issue? When do they need to come in to see you? Do they need to come in to see you the next day? Do they need to see, maybe give it a week of Advil, ice, rest, and see how they do? What's your approach to telling the kid or the parent who's had a knee injury when they need to come in to be seen by a sports medicine doctor?
Yeah, I think within the first week is usually helpful. I think if they can't bear weight, they should come in as soon as possible because you were looking for things that are more structurally concerning. But if they can put pressure on it, they got a swollen knee, I think in the first week is reasonable. Again, going back to the concept, if you're going to treat an ACL injury surgically, you're probably not going to be doing it until the knee cools off anyway. So, but I think it's nice to go ahead and get the process rolling, get the therapy going, get an established relationship with a physical therapist that you're going to be working with during this time after surgery. There are a lot of things that you need to get lined up for this ACL surgery to get things right. So I think in the first week is appropriate. Again, unless they can't bear weight. If they can't bear weight, the sooner the better.
Right.
So when you have somebody signed up for surgery and you tell them, here's what you need, can you tell me a little bit about your approach on how do you use their own tissue? Do you use somebody else's tissue? Do you start in therapy right away? Do you brace them? What's your general approach to a patient who has a tear that needs surgery?
Yeah, and that's a whole discussion, take up an entire clinic visit, because it's so important, and that's evolved, as you know, too, over time. For the most part, you cannot repair their own ACL back together. For the most part, you can't sew it together. The blood supply is not that great. The local biologic environment inside the knee joint with the joint fluid is not conducive to the ACL healing. There's active research going on. Some of our colleagues from Harvard and elsewhere are actively looking at research in order to use the patient's own ACL by sewing it back together, but that's not quite ready yet for prime time. So for the most part, we use a graft to replace the ACL, and that's evolved considerably. There's several common grafts that are used in the United States. The most common is the patellar tendon, and that's the tendon between the kneecap and the top of the shin bone. You take the central third of that. It's a very strong graft. It's been around for decades. Probably 90 to 95% of all pro athletes have that graft as their graft in the United States. Now, outside the United States, in Europe and in Asia, the hamstring graft is the most common graft. As you recall, the hamstrings are the muscles in the back of the thigh. The tendinous attachments occur right below the knee on the inside part of the shin bone, and it's a very good graft to use. You use actually a couple strands of the tendon. They look like pieces of fettuccine or linguine, and they can be doubled over. They form a very strong graft. There's a lot of research going on with the quadriceps tendon. That's the tendon above the kneecap. Only about 5% of all ACLs are done with the quadriceps tendon, But my prediction is over the next 10 years, that's gonna really become a viable graft, not only for adults, but also for kids. Because one thing we haven't talked about is that in skeletally immature patients, which we see unfortunately a lot of ACL tears now, where their growth plates are still open, you wouldn't want to use some of the grafts you use in adults where there's a piece of bone at the end of the graft, because then that might affect the growth curve. Whereas the quadriceps tendon is a very strong graft, but does not have that same problem. And so you can use in both adults and in kids. Then finally, several surgeons like to use what are called allografts. Those are cadaver grafts or donor grafts. And my preference is not to use cadaveric tissue. They were used a lot over the past couple decades ago, but they've been found to have a very high failure rate, up to 4 times higher failure rate in young people. People my age, doesn't matter if you use a cadaver graft or they use their own tissue, but in young athletes in their second, third decades of life, the failure rate's up to 4 times higher than if they use their own tissue. The other downside of cadaver grafts is you have to buy the graft, which is an expense that your insurance may or may not pay for. The grafts can become contaminated, which means they increase your risk for bacterial infection, as well as viral infection. Even though they're tested and they're produced by approved tissue banks, they can still be contaminated. And also, it takes your body longer to accept the graft. You know, one of the things I hear all the time on TV is that a pro athlete had a cadaver graft and he was back on the field so much quicker because it took his body so little time to get over it. It's actually the opposite. The pain is much less, much sooner, because you don't harvest the tissue from your own knee. But for your body to incorporate it into its own, it takes much longer biologically. And so I tend to keep those patients out even longer. But for the most part, I will not do a cadaver graft on anybody under the age of 30, because I think that the risk is too high in terms of that graft failing. Now, if they have a multiple injured knee where they've had several surgeries or they have multiple ligaments, then you may have to consider that. But for the isolated ACL tear, I tend not to use an allograft in that young population. What's your preference for grafts, given the outline I just mentioned?
Yeah, no, I think you summed it up nicely. I think if activity level drives my graft choice. So if somebody comes in and they're 50 years old, they stepped in a hole and tore their ACL, their knee is buckling for everyday life, but they don't do any sporting activities, then I think you can use cadaver tissue and have a very low risk of recurrence. But if you're a 17 to 25-year-old who's playing soccer or football 7 days a week, your exposure to things that tear the ACL are a lot higher. So you want a really good graft that's going to lower your risk of recurrence. Now, recurrence is not zero, no matter what you use. And that's the frustrating part. Again, activity level drives the risk of recurrence. You tore a normal ACL, you can tear a reconstructed one. And that's a real kick in the stomach for a lot of people who've had that surgery and have to go through that process again. But I typically, my go-to graft is usually patellar tendon graft. If it's a skeletally immature patient, I would typically use hamstring, but I'm moving more toward quad tendon because of the size. It's a robust graft that I think is a really nice option. So yeah, but again, using your own tissue is good. And I got the benefit of going over to Japan and China to give talks about 8 years ago now. And that they're largely hamstring graft, only hamstring graft. And there was a talk that was presented in Tokyo that they looked at high-level athletes and they compared hamstring graft to patellar tendon graft, and their high-level athletes, the patellar tendon graft actually did better than the hamstring graft, which kind of caused a big sigh in the room, because that was like, you're not supposed to say that because of how widely it's used. So again, if I was a professional athlete, I would use a patellar tendon graft, so I probably would do the same for anyone else at a high level.
The only other thing I agree with that 100%. The only thing I would do differently in terms of the patellar tendon is not my go-to, would be if the person did a lot of kneeling, because it does have a higher instance of kneeling discomfort. For the pro or collegiate athlete, that's not usually a problem. But I've had several patients who were, priests in the ministry, carpenters, plumbers, maybe not the best choice, only because it does tend to cause a little more discomfort when you kneel, which unfortunately is something that somebody have to deal with in their normal activity.
100% agree.
So,
100% agree. Yeah, if you have a wrestler, for example, like I'd be more prone to do a hamstring graft in a wrestler than a patellar tendon graft, just for that reason. I think that's
yeah. So what's your thoughts, after surgery? Is this something, when I had my surgery, I was in a cast for 3 months. Do you use a cast, do you use a brace? What's your thoughts on immobilization? What about therapy? Do we have to even do physical therapy, or is once the graft is in, person's good to go? What are your thoughts on all that post-operatively?
Yeah. Yeah, I mean, therapy is the 100% thing that gets people back to where they want to go. I mean, the surgery is an important part of that process, but you can't do an ACL reconstruction and not have adequate therapy because you won't like that knee. But I don't cast anybody. I don't really brace anybody. I find that braces are hard to wear. There's really no data that says it matters. Again, braces will control the side-to-side movement of the knee, but they won't control the rotation, and so the ACL is a rotational issue. So I haven't braced in the last 12 years and haven't had anybody with an issue with it. And therapy for me, early on in my career, I would say, we'll get you going in therapy after a first post-op visit. 10, 12 days after surgery. Now I get people into therapy within 3 to 5 days. I think the earlier they move it, the less swelling they get, the easier it is to get their knee straight in particular. I think people do better. Their quads activated a lot faster. And again, the quad strength is the thing that's going to make them get back to sports, or the quad control is going to make them feel more comfortable getting back to sports. So I want to get that going right away.
And what's your basic? We don't have much time left, but what's your basic outline as far as when you let people go back to kind of various milestones of activity? What do you tell them in general?
Yeah, they're allowed to put pressure on it as tolerated right after surgery. I usually tell people to use crutches early on until their muscle wakes up, just because I don't want them to have their knee fall, or have them fall or lose their balance and hurt themselves. Most people will self-limit with that. The first 2 weeks, I think people are pretty uncomfortable. Swelling, soreness, raw feeling from the incision. So I would say that you're going to feel worse for the first 2 weeks. And then from week 2 to week 6, things will gradually get better. And by 6 weeks, most people are walking around pretty comfortably for everyday life. 3 months is when we let you start running. Unless you had a meniscus repair, we may hold off for another month from that standpoint. When I say running, it's on even surfaces, straight ahead, no changing directions. Some sports specific activities, some lateral movements, agilities, somewhere around 4.5, 5 months, depending on how the strength is, in preparation for return to sport at 6 months, which I don't think happens that often. I don't think people are actually as ready at 6 months as we think they are. But that would be the earliest I let people start ramping up specific activities related to their sports. I would say that more commonly people 7, 8, 9 months before they're not thinking about their knee as much, maybe even 12 months in some of the data we have, that they may take them that long to get their sense of where the knee is. Again, I think 6 to 9 months is when people kind of get back to where they're starting to think about having confidence to return to play. And I haven't found there's one specific thing that I can use to say you're perfect, you're ready to go. I find that people will tell me when I tell them when they've gained their confidence and trust back in the knee. And as they gain their confidence and trust, which usually is corresponded with their strength and their symmetry from side to side, that's when I think they're more likely to be ready to go do what they want to do.
And what do you tell them when they say, well, am I going to be 100% Dr. Smith after I'm done with my rehab?
That's hard to tell somebody they're 100%. I mean, I think anytime you've had an injury, whether it be your knee or your shoulder, you're always going to know that you had an injury there. But your effort in physical therapy, and as much as you can get symmetry and side to side in both your hip muscles and in your thigh muscles, I think you're more likely to feel more normal with more strength. Mm-hmm. But I think having 100% is always a challenge after you've had a big operation like that.
One thing I always try to tell patients also is there's a lot of emerging research on the mental side of things of getting back to sports. There's a thing called kinesiophobia, as you've heard of, fear of activity. And there's, that's the most common cause of football players of not going back to play football, is fear of re-injury. And that's not something to be dismissed easily. We can worry about the grafts and the rehab and getting their strength back, but if they're not there mentally, then I think you're wasting your time, because it puts them at risk for injury. They're not going to have fun, especially if this is a recreational athlete. And it's something that we talk about. I tend to bring my patients, let them know it's okay if you have that, because it's very common even in pro athletes. But I think that's an area of emerging research as how that affects their ultimate return to sport, their ultimate success of coming back after this kind of surgery.
Yeah. Yeah, I mean, just for everybody out there, Dr. Matava published that paper when he looked at the largest cohort in the country. It was like 1,500 patients across the country, and one of the biggest reasons why people didn't get back to the previous level of sports was fear. It wasn't necessarily the physical measures of how they did. It was concern in the office. When I can tell often when the parents are ready for the kid to go back, and the kid is a little hesitant. I said, listen, if you're feeling like you're a little nervous or fearful about this, you're not alone. There are a lot of people who don't go back to their sport at the same level because they don't want to have to go through this process again. It's a hard process. But those are really passionate and really love their sport and are willing to risk it, and don't worry about that physical challenge that they had. I think can do a really good job of getting back to their sport with an ACL reconstruction.
Yeah, good. Well, Matt, I think this was a fun half hour. I'm sorry we lost a little time with because of the signal, but any final words you leave to the patient population out there regarding the topic we're talking about?
Yeah, I think my number one thing is go play. Injuries happen. We got the ability to help you get back and do your sport. But if you can try to do something in different seasons just to minimize your exposure to things that may tear your ACL, do different sports, train different muscle groups. Sports are supposed to be fun. Just go have fun. Do as much as you can, because when you're my age, I'm not quite as old as he is, but when you're my age, you're going to want to appreciate having all these different things that you were able to do that you can enjoy and make life full.
Yeah, those are all great points. And again, from Matt Smith, this is Matt Matava. I want to thank you. Again, we're from Washington University Sports Medicine Division. We're at the Orthopedics Center on Highway 40. If there's any questions you have, you can certainly contact us through email or any other questions. We'd be glad to take care of you. And enjoy sports. Be safe out there. And thanks again for tuning in. Good night.
Thanks, everybody.